to this e-learning session today. I am Dr. Prem Sekar in Chennai, and my brief today is to talk on the diagnosis of patent ductus arteriosus. Okay, so this is the scope of the presentation. I structured the presentation in such a way that we start off and end with a couple of data interpretation quiz slides, and then we look into the histopathology and pathophysiology of patent ductus arteriosus, which is quite important because it has quite a lot of bearing on the understanding of hemodynamics and the management of patent ductus arteriosus. Then we would look at the clinical presentation, followed by investigative modalities, and we'll round it all up with differential diagnosis. The management will be management of PDA will be done some other time, I presume. So let's start off with this slide. This is a case scenario of a 3-week-old neonate. I would like you to run through the findings given on the right side of the screen and the X-ray, and give me your diagnosis. So this is a neonate who presented with no apparent cyanosis, was quite tachypneic, and had intercostal and subcostal recession, flaring of the alar nacre, head bobbing, all features of distinct respiratory distress, had bounding pulses, and on auscultation had a loud and single S2 with a harsh ejection systolic murmur and an early diastolic murmur over the precordium. And all features of heart failure, which were despite maximal medical management with anti-failure therapy. So, what is the most probable diagnosis in this neonate? Truncus arteriosus, Gaurav Agarwal, that is good. So this is truncus arteriosus, and truncus arteriosus with the main pulmonary arteries coming off the truncus is a different, it's a very difficult differential diagnosis for PDA, and this is one condition which needs to be borne in mind. Just goes to show that any neonate presenting with cyanosis rules out an isolated, uncomplicated patent ductus arteriosus. So this is our next slide, which is a CAT data on a 3-year-old female child. If you could just look through the data and give me your diagnosis along with the X-ray findings. You have only the saturation parameters, no pressure parameters, but it should be able to give you a fair idea of what the cardiac pathology in this 3-year-old female child, as well as the physiology to some extent. Okay, the thing to note here is the step up in oxygen, which is seen in the right ventricle and the pulmonary artery. A step up of at least 6 to 7% between the RA and yeah, and also there is a differential cyanosis between the ascending and the descending aorta. So these parameters are indicative of this child having 2 shunts at the post-tricuspid level. The first one at the interventricular level, a VSD, predominantly shunting left to right. Note the ascending aorta saturation, which is only 95%, and a second shunt between the ascending aorta and the descending aorta, in this case a PDA, shunting right to left. So clearly the chest X-ray also corroborates the findings of a child with severe pulmonary artery hypertension, shows a dilated pulmonary artery, a small heart, dilated right atrium, dilated proximal pulmonary arteries, and the suggestion of peripheral pruning of the pulmonary vasculature on both sides. So it's important to understand that PDA can be associated with other lesions which can affect the hemodynamics of the shunt. Now, patent ductus arteriosus, the incidence is roughly about 1 in 3,000, with a female preponderance of 2 to 1. The genetics is usually multifactorial with a genetic preponderance and a vulnerability to some environmental factors, which mostly is the rubella infection in pregnancy. This is a very important slide, which is the morphological classification of PDA by Krichenko, and it shows you that the morphological variations are due to different areas of constriction in the ductus. Now, to be able to understand the morphological variations, it is important to understand some form of the histopathology of the ductal wall. When you look at the histopathology of the ductal wall, it's slightly different to that of the histopathology of the adjacent aorta and the pulmonary artery. The histopathology of the ductal wall shows an intima that is thicker, a media which is with a single layered elastic lamina, and variable amount of mucoid material, and the specific arrangement of the smooth muscle cells in the form of a spherical arrangement rather than the circumferential arrangement that you see in the aorta and the PDA wall tissue. The media, by virtue of being a single-layered structure, is prone for disruptions, with the effect that the smooth muscle cells from underneath the media protrude through these disruptions, proliferate, forming what are called intimal mounds, longitudinal ridges, which are called intimal mounds. Now, what is the mechanism by which ductal closure is affected? Antenatally, the ductal patency is maintained by a high concentration of prostaglandins. This prostaglandin is sourced from the maternal placenta, and also the fact that their metabolism in the fetal lung is very much diminished ensures a high concentration of these endogenously produced prostaglandins. These act on the smooth muscle cells and keep them relaxed to ensure ductal patency. After the baby's birth, the high oxygen tension causes inhibition of the voltage-dependent potassium channels in the smooth muscles, and this results in a massive influx of calcium into the smooth muscles, causing smooth muscle contraction as well as contraction of the longitudinal ridges or intimal mounds. These two cause functional closure of the ductus, which happens within 24 to 48 hours after birth, and subsequently endothelial infolding and mucoid degeneration with fibrosis complete the ductal closure, resulting in the ligamentum arteriosum. In rubella, the presence of smooth muscle cells are significantly decreased, and hence the reason for an increased incidence of persistence of the ductus arteriosus in mothers who have had rubella during their pregnancy. Same way, in premature infants, the ductal wall tissue is highly sensitive to prostaglandins, and hence the reason they remain patent, as well as their response to prostaglandin inhibitor medications. When you look at the ductal constriction, most commonly the ductal constriction happens at the pulmonary arterial end, and that is why majority of the ductus are conical and are called type A PDAs. But it's been noted that ductal constriction can also happen at the aortic end or in the middle of the ductus, giving rise to the various morphologies. Understanding that is important for the management of the ductus arteriosus when we go for percutaneous closure of the same. So these are the clinical groups, the various clinical groups that we are going to look at. If you can see, the first three or the first four would allude to PDA and the different hemodynamic manifestations that you see in them with different times. And the last one is the PDA with complications, which we will look at briefly. So roughly, the PDA can be looked at in all these 5 groups. Now, moving on to the symptoms and of patent ductus arteriosus. The symptom is predominantly due to the left to right shunt across the ductus from the systemic to the pulmonary circulation, and this is determined by 2 major factors. Number 1 is the morphology of the ductus, where the length of the ductus, the narrowest portion of the ductus, and the elasticity of the ductal wall causing impedance to flow are what determine the flow. These cause some resistance to flow in the ductus. Number 2 would be the relative resistance between the systemic and the pulmonary circuit, which would the pressure gradient across the aorta and the pulmonary artery, which would determine the magnitude of the flow. Congestive cardiac failure is the predominant symptom that you see with PDA, and this is mainly seen in moderate to large size ductus, mainly in infants and younger children, where excessive pulmonary flow has caused pulmonary overfiltration with consequent pulmonary fluid overload, alveolar fluid overload, and a decreased lung compliance causing an excessive work of breathing. Chronic overloading of the left ventricle because of the increased pulmonary venous return in the adults with PDA, the moderate to large size PDA, causes distension of left atrium and left ventricular chambers. Consequently, they have a higher end diastolic pressure. The left ventricle then compensates by increasing the stroke volume, and over a period of time hypertrophies to normalize the wall stress. Also, neuroendocrine adaptations increase the heart rate and contractility, and the diastolic runoff decreases the diastolic pressure, with the result that a combination of decreased diastolic pressure, increased wall tension, increased oxygen demand, all these factors cause endocardial ischemia and fibrosis with poor LV function and congestive cardiac failure. In the adult, heart failure is frequently associated with atrial flutter fibrillation. If the left to right shunt persists for a long period of time, then hypertensive pulmonary vascular disease ensues. This is predominantly due to microvascular injury in the pulmonary vascular endothelium, which causes release of growth factors and enzymes, which in turn result in intimal proliferation and medial hypertrophy. Endothelial dysfunction and platelet activation also compounds the issue with obliteration of the pulmonary arterioles and increase in pulmonary vascular resistance. Sometimes you find that the underlying pathology is not, the pulmonary hypertension is not per se because of the left to right shunt, but because of primary pulmonary hypertension. And in these, the pulmonary hypertension does not return to normal even with early interruption of the ductal shunt, and it continues to progress with adverse consequences. Endarteritis is a very rare complication of patent ductus arteriosus with an incidence of about 1%. Fortunately, not seen very commonly nowadays. The endarteritis usually occurs at the pulmonary arterial end, and any mycotic embolism that you see is into the pulmonary end rather than the aortic end. Aneurysm of the ductus arteriosus is reported with an incidence of almost 8%. It's reported in infants and neonates. Many a times resolving spontaneously. Sometimes in older patients post coil closure of PDA or infective endocarditis. The aneurysms can rest on adjoining structures and cause symptoms due to pressure on the left, recurrent laryngeal nerve, can compress the left bronchus and cause collapse of the lungs, and occasionally or very rarely can cause dissections which may extend into the pulmonary artery or very rarely into the aortic site. The signs in patent ductus arteriosus are again dependent on the size of the shunt. Many a times with small PDAs, no major signs are found, but with moderate PDAs with a big left to right shunt, you may find all the major feature signs of a significant left to right shunt, like the apex apical impulse being shifted down and down, a hyperdynamic apical impulse, a palpable thrill mostly in the pulmonary area, which is usually confined to systolic, occasionally, very rarely systolic or diastolic, and extending to the suprasternal area. The peripheral pulses are brisk, and the blood pressure shows a wide pulse pressure, usually exceeding 45 millimeters of mercury with a significant shunt. Auscultation, you find the classical continuous murmur. It was described by Gibson. It's worth going through that. He described it thus: it begins after the commencement of the first sound, it persists through the second sound, and dies away gradually during the long pause. The murmur is rough and thrilling. It begins softly and increases in intensity so as to reach its acme just about or immediately after the incidence of second sound, and from that point gradually wanes until its termination. The second sound can be heard to be loud and clanging. Now the second sound accentuation is because of enhanced closure of the pulmonary valve. It splits normally and varies normally with respiration. Eddy sounds are sometimes heard in the pulmonary area. This is like a bag of rocks in a bag which is being shaken. With increasing pulmonary vascular resistance, the T2 becomes accentuated but not single. And with severe pulmonary hypertension, pulmonary ejection sounds may be audible. Paradoxical splitting is confined to patients with large shunts, usually in older children. In addition to the classical continuous murmur, a couple of other murmurs have been described. The second one being what's called the abbreviated murmur, which is pretty much like the classical continuous murmur, but it fades away quite abruptly after the second heart sound. So the systolic component is more prominent with a very insignificant diastolic component. And the third is a non-specific murmur, which is a soft ejection systolic murmur commonly in the pulmonary area, which cannot be directly attributed to a PDA. It's usually seen in patients who have extremely small patent ductus arteriosus or very large ones. So we are moving on to the investigative modalities. We'll be looking at chest X-ray, ECG, echocardiography, and angiography. These are some of the X-rays that is typically found in patients with patent ductus arteriosus. You have on the left of the screen is X-ray of a child with a patent ductus arteriosus, and on the right, X-ray of an adult with patent ductus arteriosus. And what is described in these X-rays is a slightly prominent pulmonary arteries, a slight prominence of the aorta above the pulmonary artery, and a mildly increased lung vascularity depending upon the size of the shunt. Now, if you look at these X-rays, the one on the left and the one on the right, I would like you to comment on what you see here. Okay, so I have a comment here on the right with PAH. Okay, now if you look, I'm sorry about the quality of the X-ray, but if you observe carefully, you will find that on the right is a large PDA with PAH as pointed out, but also there is some calcification in the ductal wall. So this is something which you should always look for in adults with patent ductus arteriosus, which has implications on the management, because you cannot ligate a calcified PDA, nor can you go and put a device into it, because these are like eggshells and can crack with very dramatic results. So these are the ones where you would put a covered stent to exclude the PDA. So on the right, the adult is a large PDA which shows calcification. On the left, as you have rightly suggested, there is a child who has had a coil embolization of the PDA. So you should always, since these are being done quite often now, you should always be open to the idea of any devices or coils in that position in a child, which would suggest that the child had something, a percutaneous interruption of the ductal shunt. ECG is unremarkable, and except when you have severe pulmonary arterial hypertension and long-standing PDA, you would have right axis deviation with RV hypertrophy. Otherwise, it's sadly unremarkable. Some of the older textbooks point out that an upward concavity in ST segments in lead 2, 3, AVF, V5 to V6 is a useful pointer to PDA, as it's not seen in other congenital heart defects. It's something which you can take it for your exam. Now moving on to echocardiography, which is how we diagnose most of the PDA. This is the typical parasternal short axis view, where you see the aorta in cross section, and you see the right pulmonary artery here, the left pulmonary artery here, and here you have a patent ductus arteriosus descending aorta. So this is the typical two-dimensional echocardiographic view, and here you see the color flow across that. And if you look at this, this is a moving image, video image of parasternal short axis view of patent ductus arteriosus with and without color flow. The PDA is being pointed out. You see the flow is from the descending aorta into the pulmonary artery, and the PDA inserts into the proximal portion of the left pulmonary artery. And this is the same baby, the PDA you saw in the earlier slide, and Doppler interrogation of the ductal shunt, showing a left to right shunt with a left to right pressure gradient of only 24 millimeters of mercury, which suggests that the pulmonary arterial pressures have really fallen down to normal, as you would expect it to be. And looking at the trace of the Doppler, you find that the diastolic dip goes quite down, which tells you that the flow is maintained mostly during the systolic period. This is again an echocardiographic view, a suprasternal arch view, where you see a small restrictive ductus shunting from aorta into the pulmonary artery at this point. And this view is commonly seen only in very small babies and difficult to reproduce in older children and adults. So here, again a parasternal short axis view showing a ductal shunt. However, in this case, the ductus is quite large, and if you notice the flow, you'd find that it's fairly smooth laminar flow with not much of turbulence, suggesting that the duct is not too restrictive, which again goes on to suggest that this is a child with a large shunt, a chronic pulmonary overload situation with moderate to severe pulmonary hypertension. M-mode is a useful diagnostic tool to quantify the shunt. The left atrium to aorta ratio is commonly used in premature babies and neonates to quantify the shunt. Anything beyond the ratio LA by aorta ratio of more than 1.5 is considered significant. These are some of the Doppler flow signals seen in neonates. As you can see in the section A, you have systolic flow, and during diastole there is reversal of flow in the ductus, suggesting very severe, very high pulmonary artery pressures. And in B, you have predominantly systolic flow. In D, you have predominantly left to right shunt, and E, with severe pulmonary artery hypertension where the ductus is flowing right to left. Again, various diagrams showing the spectral Doppler in PDA. These can be used to assess the pulmonary artery pressure as well as quantifying the left-right shunt. Doppler of the renal artery flow with reversal in the descending aorta as well as the renal artery can be again used to quantify the amount of shunt. Hiroshi et al. In 1987 published a very nice paper where the velocity of the blood flow in the left pulmonary artery in diastole in infants and neonates with PDA correlated very well with the left-right shunt ratio. So this is another useful marker for quantifying the ductal shunt. Harling S in 2011 published a nice paper where the maximal color distribution in diastole in a parasternal long axis view was taken. The area of the pulmonary trunk and the area of the ductal shunt area were quantified, and it was found that when the ductal shunt area was more than 40% of the area of the pulmonary trunk in the parasternal long axis view. It correlated well with a QP by QS of 1.4 to 1. Another way to quantify a ductal shunt would be by measuring the flow across the left ventricular outflow tract versus the right ventricular outflow tract, or the flow across SVC versus the left ventricular outflow tract flow. These can be measured using the equation heart rate times velocity times integral times area. The LPA diastolic flow, as we have pointed out earlier, is a good indicator of the quantity of ductal shunt. Now, in an adult with large patent ductus arteriosus or older child with PDA, the pulmonary hypertension prevents the left to right shunt, and echocardiographically you may not have a quantifiable shunt which could be demonstrable, with the result that you may not appreciate the presence of a PDA by echocardiography. Indirect pointers to this are flattening of the ventricular septum, a hypertrophied right ventricle, or the presence of a high velocity pulmonary regurgitation jet. In such cases, you should look very carefully for the presence of a patent ductus arteriosus. However, in the absence of a color flow, you may still find that it's difficult to ascertain the presence of a PDA, and in such patients, contrast echocardiography can be a useful tool, showing the presence of microbubbles in descending aorta when you inject it, rather than finding it in the pulmonary artery or LPA as you would normally expect to in a patient with a left to right shunt. PDA in premature babies have a higher incidence for reasons pointed out earlier, which is basically enhanced sensitivity to the prostaglandins. The implications are heart failure, pulmonary damage, cerebral splanchnic coronary renal flow schemes, and the significance of PDA in neonates was assessed by Tavera Insi et al. In a very nice paper published in 2009, where he quantified it into small, moderate, and large based on the parameters of two-dimensional measurement of the diameter at the pulmonary end, the ductal velocity at the pulmonary artery end, with a velocity less than 1.5 meters per second indicating a large duct, the LPA flow velocity in diastole more than 0.5 meters per second in large ducts, less than 0.3 meters per second in small ducts, LA by aortic ratio more than 1.6 indicating a large duct, E by A ratio of the mitral valve with more than 1.5 indicating a large shunt, retrograde flow in aorta more than 50% in diastole indicating a large shunt, and LVOT to SVC flow ratio of more than 4 indicating a large shunt. Another interesting paper by Abrams and Walsh in 1993 looked at the morphology of echocardiographic morphology of the ductus, mainly the variations in ducto-aortic angle in 5 groups of patients. They were those with PDA, coarctation of aorta, pulmonary stenosis, pulmonary atresia, and hypoplastic left heart syndrome. It was found that patients with PDA and coarctation of aorta had a wide ducto-aortic angle, usually a mean of 107 and 104. The ones with hypoplastic left heart syndrome also had a wide ducto-aortic angle with a mean of 98 degrees. And the group with pulmonary stenosis and pulmonary atresia had a very acute ducto-aortic angle, usually 43 mean for the PS group and 25 for the pulmonary atresia group. So this is important again for planning management of these patients with pulmonary atresia when you are going to stent the ductus. Moving on to angiography. These are some of the angiographic morphologies that you see, and it's important to recognize them to be able to successfully manage them percutaneously. This is the lateral aortogram, which profiles a very small patent ductus arteriosus, conical in shape, type A patent ductus arteriosus with a small shunt into the main pulmonary artery. You see the valve profiled here. And this is a lateral aortogram in an older patient with a much bigger patent ductus arteriosus, and you can appreciate the slow shunt into the pulmonary artery, indicating high pulmonary artery pressure. This is a child with severe pulmonary artery hypertension and PDA, where a balloon occlusion is being done. Now, I would like you to look at this angiography and tell me what you see. What does this diagram show? Okay, we have an answer. We have AP view iotogram fill LPA. I would like to point out here that this is an iotogram which shows a left aortic arch, and you have a left pulmonary artery which is filling through possibly a ductus here, which is not very clear. But you also see a disconnected right pulmonary artery filling through another structure here. So let's move on to the next one. So this is the same child where a selective injection is done into the structure perfusing the right pulmonary artery. Now what would this be? And on the right you have an angiogram where selective injection is done into the duct with perfusing the left pulmonary artery. So this is the same patient. On the left you have selective injection into the structure perfusing the right pulmonary artery, and on the right you have a ductal injection perfusing the left pulmonary artery. Collateral from REMA is one answer. Okay, so I would like to point out this is a child, a neonate with bilateral patent ductus arteriosus in the setting of pulmonary atresia with VSD and non-confluent pulmonary arteries. So what you see here is bilateral patent ductus arteriosus, and the embryological explanation for that is that you have the pulmonary arteries which normally arise from the sixth aortic arch. The proximal part of the pulmonary artery regress spontaneously, with the result that you have ductal supply to both left and right pulmonary artery in the setting of pulmonary atresia. So that was a case of bilateral PDA. Okay. Okay, so I would like you to now look at this slide and tell me what you see here. This is again a very interesting angiography. What do you see? What is the structure that is opacifying in this view? So you see a left aortic arch, a right aortic arch, and you see another structure from here filling a well-formed pulmonary arterial confluence. This is the same patient. This time the pigtail catheter is into the structure which is coming off from the ascending aorta, distal ascending aorta, and opacifying the pulmonary arterial confluence. Now, what is this structure? PDA type 4 truncus is one answer from Michelle Vegas. PDA type 4 truncus. Okay, so this is another slide which shows an angiography with a similar structure coming off from the distal part of the ascending aorta and opposite to the innominate, and supplying the right pulmonary, lower segment of the right pulmonary artery. So, it's not PDA type 4 truncus. I would like you to look at this picture and tell me persistence of which structure has resulted in the pathology seen in the previous slide. And the answer is persistence of the fifth aortic arch. Now, this is a very commonly ignored or unrecognized pathology where you have a big vessel, the persistent fifth arch, arising from the distal part of the ascending aorta, just proximal and opposite to the ostium of the innominate artery, and joining either into the aorta when it forms a double aortic arch, or into the pulmonary arteries when it would be a systemic to pulmonary connection, usually seen in cases of pulmonary atresia and severe pulmonary stenosis, but also known to occur in structurally normal hearts, into a normal pulmonary confluence when the clinical picture is similar to that of a large patent ductus arteriosus. So this is an important differential diagnosis of persistent fifth aortic arch with systemic to pulmonary connection, which you should always have in mind as a differential diagnosis for PDA. The last couple of slides, some of the other differential diagnoses for PDA would be arteriovenous malformations. These can happen anywhere, and the unusual location of the continuous murmur should alert you to the possibility that this is not a patent ductus arteriosus. On the right is an angiography of a coronary cameral fistula. Again, when the coronary cameral fistula is from left to right with a significant shunt, you can hear a continuous murmur, again located in an unusual position. This is the aortopulmonary window. You can see that this patient has undergone surgery earlier. So in this case, this was the residual aortopulmonary window which was then successfully plugged. And the ruptured sinus of Valsalva when it goes into a right side structure can again present with a continuous murmur, but in an unusual location. Okay, so that ends my presentation. I wish you all the very best for your exams and career in pediatric cardiology. Thank you.